And just a brief introduction. You can already learn that one of the reasons that we are having this gathering today and tomorrow is the emphasis on radiation safety, which requires better radiation dose management. Interventional radiologists and cardiologists, we carefully plan each procedure. We consult the referring physician, provide detailed explanation on the procedure to the patient, and obtain informed consent. Please remember that when you obtain informed consent for the patient, and if you are expecting a procedure that will require long fluoroscopy, complex procedure, etc., you are obligated to explain to the patient the dangers of the radiation and explain if there are any alternatives like surgery or any other you can think about at the same moment, and then it will be up to the patient to consent and sign this. And moreover, such cases better be invited for the checkup. Just look at the skin of the patient to see if there are any damages there or color changes, etc., etc. It is extremely important, and this is our responsibility as physicians. This attitude should be part of our daily routine. Please. Next slide. Procedure planning. We are about to know what are possible complications of the procedure we are going to perform, and whatever we can do to avoid it. The most important contributor of the radiation exposure is fluoroscopy. I'm talking about it during the procedure, not talking about the CT before, etc. And time-efficient performance of procedure will ultimately lead us to shorter fluoroscopy times, less DSA runs, and reduce the exposure dose to the patient and to the staff. Cone beam CT geography became a game changer in interventional radiology. It allows to perform procedure based on very few acquisitions, and basically you can do the procedure guidance navigation without even using fluoroscopy. Next, please. Fluoroscopy protocols, we have to be able to choose protocol, and as Dr. Vasilev have mentioned, this bandanology, according to Donella, is like it's in front of you, and you have to know that there are about 100 organ programs or exam sets in the new angio equipment. It should be preset with the vendor when they install the equipment, and your medical physicist. First of all, X-ray beam spectrum, focal spot size selection. It affects high contrast resolution, and parameters like that influence those rates, including default pulse rate, pulse width, spectral filtration, detector dose level, and maximum allowable dose rate. All staff members should be trained as part of this radiation safety culture. Next, please. So now we've been talking about danger of exposure. The main problem is more dangerous than the exposure, because the exposure is the danger of the process. For example, it is statistical, so it could be 1 in 1,000, etc., etc. But we are obliged to use protective aprons and collars and glasses, and they are heavy. And you have to identify and stop performing activities that cause this pain. We'll talk about it in detail. You have to place the monitor in front of you, a slightly lower level than your eyes, so you don't have to move your head too much. You have to keep the monitor in the viewing distance, and clearly it's better to have a big monitor, then you don't have to use magnification, which carries a higher radiation exposure. And the table height adjustment is also very important. Please remember that the table height should be your elbows, depending on your height. Of course, they should be in neutral position, not bent and not too open, because it also can cause, next please, some pain in the cervical area. Procedure planning. It should integrate those management measures, and this is efficient and optimal use of radiation. And then saying it again, not irrational fear. Fear, not negligence, please. Next. CT angiography or MR angiography should be set prior to almost any endovascular procedure. CT angiography has become a routine must to have imaging for diagnosing and localization of bleeding, for example, in setup of trauma or gastrointestinal bleeding. Good pre-procedural imaging allows us proper planning of the access, choice of selective catheters for quick access, and safe and accurate performance of the intervention. Just a word about the catheters. You should be aware that some of the catheters are not radiopaque enough. You might not see them well when you navigate in the patient, in the arterial system of the patient. So please be aware of that and make sure that you are using the catheters. Most of them are okay, but should be careful and remember that they should be well seen. Next. We'll talk about modality-based patient radiation dose. So just a word about the C-arm systems. We talk about the KERMA area product or dose area product, which is in gray centimeter, and the cumulative skin dose, or so-called air KERMA, it's measured in the milligray. When we do rotational acquisitions like CT-like images, like on beam CT, the same quantities as in angio are used. For CT, as you well know, we use the CTDI, CT dose index in milligray, and those like products in milligray per centimeter. Next, please. This is a very important slide. Please, it's very easy to remember. Please ignore the distances of the image intensifier and the tube from the patient, but it should be, but look at the numbers. It should be over 60 centimeter, and the isocenter of the patient, besides children, because they are not 15. It should be like 15 centimeters from the table height. Table is transparent to radiation. Next, please. The ALARA principle we are obliged to live with as low as reasonably achievable. So we need diagnostic, not beautiful images. And we already know that if we use AI, the not beautiful images, diagnostic images, can be also beautiful, as good as the full radiation exposure images. And what should we do? We should try to do a fluoroscopy guided procedure or CT guided procedure in the minimal time, please. Next. There is a new definition which is accepted today in the United States by their cardiologists, and we are working on the upcoming document. And it is about the personnel protection, not the patient. And we talk about enhanced radiation protection devices, ERPD. Okay, so some people claim that ALARA is good for the staff. I disagree with that, because we are not going to have as low as achievable. We should make sure there will be no radiation at all to the staff. Clearly, it's something we should try to have it, but when you are working according with ERPD, it will make life much easier and safer. So what we use: disposable accessory radiation drapes, mobile barriers, fixed barriers, robotics. Robotics can be in another city doing that, another country, compared to standard lead aprons and limited shields. It achieves significant reductions in exposure. Again, it's for the staff. Some ERPD reducing operator and staff exposure could go up to 99%, I'll show it in a minute, and levels of protection that may allow working without orthopedically burdensome lead aprons or a reduction in lead thickness and weight, please. So if we look what happens, 80% of radiation is absorbed by the patient during fluoroscopy. 20% is a scatter in random different directions, and only 1% of the radiation coming from the tube reaches the detector. The scatter field is highly asymmetric. It could be 10 times more intense on the tube side of the patient. So we have to be very careful from down below, and then on the image receptor up the side, please. Standard protection equipment, we call it PPE, personal protection equipment, protective equipment, sorry. It has high atomic Z number materials. Lead is perfect by means of that, and this is the reason we use the lead equivalence. So, but now we are better moved to the lead-free garments, usually bilayers. The problem is the cage absorption of these materials. We use them, but they are not same with lead. If you remember the Godzilla principle, weight does matters. So lead is really heavy, but it protects in entire range. So in some European countries, lead is out already for many reasons. One of them it's not good for the environment, and we have to make sure that it's safe. One thing. The other thing is that, for example, lead collar. If you put it on yourself, there are publications already showing that they crack and the cracked particles can get into your vascular system, to the skin, and into the vascular system, and could theoretically cause lead poisoning. So if you are using lead, you have to use them. If you don't have any others lead-based collars, I advise you to put something between this and the collar itself, so it will protect you. Lead equivalence clearly varies. It depends on the scatter quality. The scatter quality depends on the weight of the patient and then many other parameters. And at tube energies over 90 kV, lead-free materials are not as good as lead. Please remember that. Next. So this equipment is less protective, less effective for CT-guided procedures. I'm sure that some of you do CT-guided biopsies and ablations, etc., and remember that these 0.5 and 0.35 millimeter thickness lead equivalent garments, they protect from 5% and 10% of fluoroscopy scatter. If local regulations specify a minimum lead equivalent thickness, it should be based on the under the apron dosimeter readings, not one outside. Remember, again, the weight is important. Next. What about occupational doses? Busy interventional radiologist is not expected to exceed 20 millisievert according to ICRP annual limits, and some studies indicate that IRs are expected to have 2 to 6 millisievert annually, but this is studies and reality could be different. Thyroid color batch dose decreased significantly in interventional radiologists, and you have to remember that the thyroid cancer prevalence after the age of 40 is going down, so it's not that dangerous. The problem is the island doses, and I'll specifically talk about radiographers later. Radiographers in the United States have a median annual dose of less than 2 millisievert and are unlikely to exceed 10. Nurses have even lower doses than radiographers, less than 1 millisievert, but it clearly depends on the setup. For example, in UK, I used to work there as a fellow, and the nurse is always in the room, and she's on the head of the patient or walking around, never leaving that, and the exposure could be high. Please. Pregnancy. I'll be very short here, but some dangers that could be pregnancy loss, congenital malformations, developmental delays, and cardiogenesis. These risks can be tissue effects like intrauterine growth retardation, miscarriage, and again, the congenital defect, childhood cancers. But we have to say that the same risks, almost similar risks, occur in the pregnancies where the embryo fetal never been exposed to the radiation. Again, we have to be careful, but remember that this is not the case. Next, please. We published many years ago, and we will be working on the next one it was 2009, CIRS and SAR, the document about guidelines for the patient radiation dose management. Vascular surgeons have the same guidelines, different, they have it, and the cardiologists, of course, have the same. Next, please. This is a very important slide by Pat Schuller, 10-year-old, but it's true even today. You can see the scatter to the operator, and the green is good, and this dark red is not so good. And now please have a look at the feet of this interventional radiologist. His hair is gone, and he's a hairy guy because of the scatter radiation coming from down below from the leakage from the tube. So remember that, and always use the shield. Next, please. Again, a large patient, large obese, most of it the same, but it could be radiation, could be almost double on additional 5 centimeters of the thickness. It was measured on the phantom. The same is true because phantom is a tissue equivalent, and entrance air care might increase it by factor of 8 when you increase the thickness of the patient from 24 to 34. Next, please. And you can see this nice graph clearly showing a dependence between the entrance dose and the size of the patient, thickness of the patient, from 16 on the left to 28 on the right. Next, please. And this is also very important. This first slide, look at the left side. When the image receptor is okay, it's on the patient, and the tube is okay because far away, 80 centimeters from the patient. Now, if you come closer with the tube to the patient, the radiation goes up to 4.2, and when you come to very close, it goes even higher. Next slide, please. Sorry, go back one, please. Sorry, my mistake. Can you go back one back? Thank you. So please pay attention, 50% magnification when the image is away and the tube is closed. You compare it 3 gray to almost 8 grays. So remember this slide as well. Next. Now on this slide, you see the mode 1 and mode 2. Please look at this carefully. And if you can see any difference between these two, okay, you know something that I don't. Next slide. Next, please. Thank you. And you see, mode 1, 100% dose, okay? And mode 2 is only 17% dose, and you go from 5,500 milligray centimeter to only 920, same quality of image. So which one you buy? I think that you know the answer. Next, please. We are working now, this work published in 2013, again, joint guideline with CIRSA and SAR. We published it 2013, if I remember properly, but now we are working on the new guidelines, updating them. They will be different, and we expect they are now in the review of the both CVIR and JVIR. They will be published in both journals by the end of the year, and it will be a guide for all of us how to behave in this hostile environment of the interventional radiology suite. Next. Going back to problems, real problems. What happens with our back when you work? We do repetitive motion patterns, left to right, to the table to take equipment, back to the patient, looking at the monitor, and we have not sufficient, depends on the what you do, but insufficient recovery time, very prolonged standing, and it's a axial loading on the back of the spine, and the body postures are crazy sometimes. Next. So, what the factors that are associated with the low back pain, the static posture I mentioned, and isometric contractions of the lumbar extensor muscle group. Cervical pains, they are associated with the use of poorly positioned ceiling-mounted monitors and repetitive head and neck movements required to view these monitors. So please make sure that the position of the monitors is really, as I mentioned, not too far and at the level, a little bit lower than the level of your eyes. Next. And this slide clearly shows you the differences stuff in cardiology, in interventional cardiology, and on the left, and the cardiologists who are not practicing, and you can see the orthopedic illnesses, 30 versus 5, significant. Cataracts, significant. Thyroid disease, also. Everything is anxiety and depression, as well as cardiovascular problems are not really the issue. And we can look at the hypercholesterolemia, which is preferred not to have it. It's again significantly higher when you practice interventional procedures. Diabetes, not significant, and the cancer again, it's not significantly higher, but a little bit higher. Next. Which factors affect the staff doses? So its main source of radiation, as I mentioned, is a patient, radiation to the staff. Scatter is not uniform. It's also mentioned, and you will see Dr. Vasilyev's presentation. The level of dose rate around the patient is very complex function, so better eliminating. Next. So what we can do, we already discussed this, just this paper by Victoria Marks from many, many years ago, but it's true today as well. So transmission is typically 0.5, as I mentioned, is 0.5% up to 5%, depends in which range you work, from 70 to 100 kilowatt. Next. And these are the different types of equipment. Sometimes it's better to use, I think that it's better to use kilt, not the entire protection, and the weight of the apron is divided by two, part on the shoulders and part on the waist. I will talk about this head protection. I think I know that this kind of head protection is absolutely unnecessary, because this is made of is very heavy, and we have enough on us. It does not protect the brain. Next, please. Something to remember, that this stuff, it cracks, and I have these images from Pennsylvania, and you can see the cracks. So there is I'm sure they have the same regulations. At least once a year, all this protective equipment should be checked in fluoroscopy. If there is any problem, you should not repair it. It will be disposed, and you have a new one. Next, please. Okay, the leg-free aprons. The protective value of these aprons is depends on the vendor, and it is used to measure attenuation and weighting factor made at different beam qualities. As I mentioned, that up to 90 kV, they're okay. Over 90 kV, lead is better. So you need the curtains up there and below, then you are okay. Next. Again, you can see this on the left side. I took the image of this, whatever they say. Dr. Vasilyeva mentioned the different vendors. So you can see that the aprons may be more efficient at 70, 80 kV, but less 100 kV, even lower than that. So you have to be very careful. And before you purchase or before you use it, look at this label, and you will know if the one you use is really what it expected to be. Next. Yeah, this is it was made by Cook many years ago. It's called Pinkerton. If you saw this movie, I'm sure you have Hang 'em High, American Western. So this protection system, it's kind of your apron is on there, and you just put it on yourself. And I have the next slide. That's me, you can see that. And this on the left is my spine. If you practice it so many years, this is the way you pay for that. So I had already 4 surgeries on my spine, and therefore you have to be very careful and try to avoid it. And when I was at their days, I had to practice after my surgery. So I made it, we booked it, so we made it ourselves in the hospital, in some workshop. And I used to work with this some months before I recovered, but I could work in a CT-guided procedure or in angio. We've been moving it from place to place, and I could work without big problem. Please pay attention that the collar is with the dosimeter, which should be outside the collar, and it reflects your eye exposure. Next. There's Professor Barry Katzen from Miami, and you can see there is a barrier which is movable, also very effective if you like to use that. It's very good, especially in the long procedures, and if the room is crowded, like a multidisciplinary team, a hybrid procedure, like in this case it was EVAR. Next. Zero gravity, it was mentioned here. It's an interesting development, and it does two. First of all, it protects the entire body, and it also has a visor, kind of helmet on the front that protects protects your eyes, and you are free to move in the room. And when you want to go for fluoro, you just attach yourself. There is a magnetic belt. Next, please. On your chest, and you can see how that works. And it is very efficient. Again, very expensive, and not any room can. You cannot fit into any room. You need a large room. It could be ceiling suspended or floor mounted, and it takes place. And it's a little bit problematic when people have to walk around in the room. But again, very efficient by means of radiation protection. And cardiologists, especially electrophysiologists, are very happy with that. Next. Okay, this is Israeli system which called RadiAction, a robotic radiation shielding device. And basically, somewhere here between two is the patient, and basically there's no scatter radiation, almost no scatter radiation around, and it's very safe to working with. Again, it's good for the cardiologists, for neuroradiologists. It's not so good for vascular surgeons, almost unusable, and not in interventional radiologists if you do biliary or prostomies or drainages, whatever. It won't work. Next. Another system is a Protego, again named for the cardiologist. The patient is surrounded by lead, so the stuff can work safely there. And you can see on the graph on the right side how efficient it is. Next. Another system is named Rampart, American system, and this is very effective and very convenient for the users, because what they have checked and they're doing that. Next slide, please. This stuff basically can work without protective equipment at all. No need in the aprons. And that is what they claim, and the people who are using them in United States, that's what they do. Again, it's expensive, but it's worthwhile because it protects the stuff that is standing on the proper side completely. Next, please. The other development is head and neck protection. And this is something that, if you remember, this is the collar that also has an extension on your chin. And this is the head protection. They evaluated it, done some phantom studies and clinical studies in Madrid with Professor Vanya and his team, and we found it very effective. This paper is coming from Germany, and they also find it very useful because it is very protective. But you do have to use glasses in this case, and you have to use the curtains and the protective thing from above also. Only if it's not possible, you can do it. This equipment is very effective for nurses and radiographers because they are walking around in the room and it can be protected. Please remember that the prevalence of the brain tumors in the interventionists is higher than in the general population, and this is the reason that we think that using of this, not the apps which are not effective, but this device, for example, is very effective. Next, please. Thanks. And this is the paper they have published, and they show very nicely how it protects in the phantom study. Next, please. Thanks. Okay, now we'll move to the future. Exoskeleton. And some of you saw this movie. Next. Yeah, so exoskeleton of the future which carries weight of the AR, but you can walk in it freely as you do, and nothing on your shoulders or on your head. Okay, this is a real work. This guy, he is an Israeli engineer who had a road accident, and he's pelagic from his neck down. And he invented this. It's called rewalk. You can walk with this and even go upstairs for about 40 minutes without any support, which is important. Next, please. And this is about this Stemrad. It's again another Israeli company that made it, and you just step into it. And I cannot show videos this case, but you can freely walk with this. Again, it has the same protection as the zero gravity for your head and the eyes, and the full protection of your body. And also remember these sleeves that protect from entering the scatter into your chest from the side. And it works nicely, and you are not, you can imagine if you have 2-3 angio rooms or cath labs and you have to walk from one another to another. You don't have to put 3 zero gravities, etc. You can take one of these and walk around. So this is the way, take it or leave it. And this, I believe, I don't know how much it costs, but it's about a third of the price of the others. Next. So what we have to do, it was paper that will be published in CVIR over 10 years ago. So the ultimate goal, our goal, is to work in the environment with 0 personal radiation exposure. And here are the essentials. You have this presentation. It will be available for all of you, and you are welcome. I'm not going to read all of them, but those are the take-home points, basically. Next. Okay, we discussed already the caps, etc. And this is a paper published less than 10 years ago. As we know, scatter radiation goes tangentially, and so nothing is really protected. So what we need to remember that these caps provide minimal brain protection, almost none, and the glasses only provide partial protection to the ocular lenses. This is the reason we have to use the shielding coming from up. Next. So reliability of lead glasses. One of the problems that we face is the capsular opacities that have a higher prevalence in the cataract, higher prevalence in the interventional radiologists and cardiologists. And the problem is that with age, it's almost the same. But we have to remember that we can diminish or avoid this damage. There are many other factors like smoking and age and male, female. So there are other confounders. So it's multifactorial. But we have to be obliged to use the glasses or any other kind of protection to avoid radiation to the eyes. Next. Okay, this is something I mentioned. If you work from femoral access, okay, you should have monitors in front of you, not here, not like on the right side, because you have a neck pain at the end of the day, or maybe even after 1 or 2 procedures. Next. Those are several types of the glasses. Okay, those are in the middle. You have the sexy sportwear glasses, which are, I think, not really useful. The lightweight glasses, the adequacy is 0.7, very light, and the classic glasses are also useful because they protect you from the sides. Next, please. And you can see here what happens if you have this kind of glasses, this one. This is the light glass. Those are the light glasses. And they are, next, almost as good, if you can see here, when using femoral access, almost as good as these classic glasses. They're much lighter. Please remember that we have to be able to, in specific, if you use the prescription glasses, you have to make sure that you put the other glasses over the prescription glasses, because buying lead glasses with the prescription, first of all, they are crazy expensive, and our vision is changing with years. And therefore, I think that the better solution is to have some protection over your prescription glasses. Next, please. They're just showing you that if you use all these measures, having the tube away, having the image intensifier close to the patient, and using the dosimeters, finger dosimeter, and the personal dose dosimeter, all of these measures will reduce your exposure and will keep you safe. Next. Next, please. Dr. Vassilieva will discuss it in more detail, I believe. And these are electronic dosimeters. There are great advantages that they are real time. You can see in real time if your exposure is high. You can even put as a monitor. It will bleep for you saying it's too high scatter. And it is very effective, and clearly everything is documented. Another cheap way to do this, using bleeper dosimeter. You put it in your pocket, in your apron, and if you are going to the danger zone, it will bleep, and then you move back. But clearly, using it, again, you have to use dosimeters as they are. Those are addition. Next, please. What about the future of these protection, personal radiation protection? Again, the weight of the aprons limits our mobility, and we have orthopedic issues. I know many others, but I'm the example of unfortunate working nearly 40 years in interventional radiology. Now, I'm very happy with my work, but I'm unhappy with my back. And these new lightweight, they become available. Are they really as protective? Not exactly, and please remember the numbers I provided to you. Next. This one shows you what is the scatter at each level. Don't forget the low down, and if you use the curtain up there and down, you are safe. Next. Yeah, what you see, this guy is working very hard, but the curtain is behind them, so not that smart. Next. We have to measure the radiation during the procedures and categorize them, okay? More than an order of magnitude for the same type of procedure could be measured. So something wrong there, you can learn the patient history, you can simulate the specific case, etc., and make sure that you will not be, and the patient will not be exposed to unnecessary radiation. I'm skipping this part because all of this will be given by Dr. Vassilieva, but the equivalent dose and effective dose for the whole body should be very clear. Next, please. Hybrid rooms. If you work with the vascular surgeons and you have anesthesiologists, nurses, radiographers in the room, a lot of people there, so it's a challenging, and these cases need a specific solutions for the protection next. What about the radiographer's role? Access to the patient, dose level, and image history. So we have to check, because if patient has several procedures, you should the physician should be noticed and should make sure that you will not use the same projection that has been used before because of the skin damage. You do the risk assessment before the procedure, and they are responsible to determine need for additional safety in high-risk patients, like large patient, pregnant patient, or of course the child. Next. And there's another paper we published for the radiographers. It was with Professor Paulo from Portugal, and this is the pathway to the safe fluoroscopy guided procedure with the safety culture. You can see medical physics radiographer and interventional radiologist, and what you have, there's a responsibility of the head of department to acknowledge that keeping teams stable and will allow them to achieve high technical and professional differentiation and minimize practice errors, maximize patient staff protection. So we have to work over 40 years in this field, and we have to keep ourselves safe. Thank you. Next. What is the optimal dose of the patient? There is no such a thing, but again, you can see this variation could be 13-fold between the highest and lower dose for each type, for the specific type, for the same type of the procedure, on the same size of patient, same difficulty. So something is wrong there, and you have to take measures to avoid this. Next. And so the management of the dose should be proactive. Radiologist, radiographer, medical physicists should work together, and we learned it from Professor Elliot Fishman, says that organizations need systems in place that allow constant observation of adherence to protocols and procedures. Next. To conclude, purpose of angiography and CT scanning is diagnosis. Radiologist's legal responsibility is the diagnosis, okay, not the procedure. Those management strategies has to respect concerns, proceed with caution in every step, and performance gaps in medical imaging must be managed to break the trend and reduce the risk. Next. To conclude, collecting and monitoring those data is very important to develop policies and make important clinical decisions. A rational strategy is required to reduce and standardize patient dose over the full range of examination times. And we, again, expanding use of interventional radiology tools by non-radiologists, like in hybrid room, it requires special attention in order to avoid amateur behavior and unnecessary exposure. And this is the place for radiographers, when they are in these rooms, to make sure that our colleagues will not be overexposed. Next. Last but not the least, I refer you again to whatever Dr. Silva showed you, the IAEA videos. Next. And this is something to mention, the three people standing on the railway. Pessimist says, oh, it's a dark tunnel. The optimist says, oh, I see the light at the end of the tunnel. Realist says, there's a train. And the train operator says, three idiots standing on the tracks. So don't be one, each of them. Next. I'm sure you know this, on the left is a Gordian knot, okay? But Gordian knot is not a good example for us. It's better to use the Borromean rings. You see the three rings, if you remove one, they all fall down. So you have to be extremely cautious and prepare yourself for a practice and going to do the procedure when you know exactly what you're going to do and in which conditions next. Thank you for your attention.